Hey future respiratory therapist and anybody watching this video, today we're going to talk about an important part of being a respiratory therapist, and that is being able to interpret blood gases. Now today we're just going to talk about the respiratory acidosis side of things, okay? So we're not going to get into metabolic disturbances. We're not even going to get into respiratory alkalosis. Those are going to be my next 2 or 3 or 4 or 5 videos, okay? Today we're just talking respiratory acidosis. So we're going to talk about ABGs and respiratory acidosis. Now, to understand how to interpret blood gases, you first have to understand normal. So we know we have a pH, we know we have a PaCO2, and we know we have bicarb. Now, I'm not even going to put oxygen in here because oxygen doesn't affect your pH balance, okay? It can affect and it can drive your drive to breathe to push CO2 up or down, but it doesn't affect the actual interpretation, okay? So I want to just make that clear if you're wondering, why is there not a PaO2 on there? It's because it's interpreted as a secondary part of it. So what we have here is when you say uncompensated respiratory acidosis, partially compensated respiratory acidosis, fully compensated respiratory acidosis, you then go on to say with moderate hypoxemia or with severe hypoxemia. The oxygen status, the PaO2 does not affect if it's a respiratory acidosis or fully compensated or partially compensated. So, having said that, then we know that these are our 3 main components: pH, PaCO2, and bicarb. Now to start here, let's start with normal. 7.40, 40, and 24. These are normal values for pH, PaCO2, and bicarb. Now we know there's a range. We know the range on pH is 7.35 to 7.45. We know CO2 is 35 to 45. And we know bicarb is 22 to 26. Those are our normal ranges. But this gives us an illustration of normal. Okay? Now, what happens when somebody goes into a state of uncompensated respiratory acidosis? Well, the term uncompensated means that there is no compensatory mechanism happening. Respiratory tells you that it's the respiratory component that's the problem, which is the CO2. We know that the bicarb is the metabolic component, and it's the compensatory mechanism for respiratory problems. Just like respiratory is the compensatory mechanism for metabolic problems. So, CO2 compensates for bicarb, bicarb compensates for CO2. Both of these things together drive your pH. Okay? So, what we see here is that with the initial disturbance, okay? This is going to be a uncompensated respiratory acidosis. So I'm just going to put it up here, okay? So we have uncompensated respiratory acidosis. And what it will look like is this. Your pH, well, first of all, let's just say this. Your CO2 goes up. Let's just say to 55. Okay? Your bicarb is initially going to stay the same. It's not going to move initially. Remember, bicarb takes time to move. So your bicarb stays the same. And what this does is creates an acidotic pH. So we're just going to say 7.25. Okay? Now, the reason we know this is uncompensated is because bicarb is normal. That makes it uncompensated. It's a respiratory because it's the CO2 that's causing a problem, and it's an acidosis because on our pH scale, we're south of 7.35. We're at 7.25, which is below 7.35. So this makes sense why this is an uncompensated respiratory acidosis. Now from here, our blood gas will turn into a partially compensated respiratory acidosis. Okay? So this is like this. Now, our CO2 is at 55, okay? So as it hangs out at 55, we're going to see that our bicarb is going to increase. Okay, so the kidneys are going to work hard to get rid of estrogen and extra hydrogen ions. They're going to retain more bicarb. The bicarb is going to go up. So our bicarb will increase to 28, and our pH goes up, let's just say to 7.28. Okay, so now you have a pH of 7.28. It's still acidotic. That's hence the acidosis. Your CO2 is high. That's causing a respiratory acidosis, but your bicarb is up. Now, the reason this is partially compensated and not fully compensated, some of you may call it compensating. So a compensating respiratory acidosis. That tells you that the compensatory mechanism, the bicarb, is increasing. As the bicarb increases, it'll pull the pH back up towards normal 7.35 to 7.45 to try to compensate for this high CO2. Now, how do you know what the problem causer is and what the compensatory mechanism is? Well, that's a good question. And the answer is this. What side of the pH scale is my pH on? Well, it's on the acidotic side. So now we have two values here that are out of range. A CO2 that's high and a bicarb that's high. But we understand that a high CO2 causes an acidosis. We also understand that a high bicarb will cause an alkalosis. And so because this is on the acidic side, then this has to be the problem causer because this will cause an acidosis. You see, this would cause an alkalosis. If you took your CO2 back to 40, we would have to make this an alkalotic pH. But that's not what we have. We have an acidotic pH with a high CO2 and a high bicarb. The cause has to be respiratory component. So this has to be a respiratory acidosis. Now, for the simple fact that the bicarb has elevated above normal range, that tells you that it is compensating. So this makes this a partially compensated respiratory acidosis. Now the problem that happens, and the reason I get so many questions over this, is because, well, how do you know if it's partially compensated or fully compensated? Well, to know if it's partially or fully compensated, you have to ask yourself, is my pH in the normal range? And so when we look at this, now we'll see a fully compensated respiratory acidosis. And this will take our pH to 7.35. Our CO2 is still here hanging out at 55. And our bicarb is now up to 32. Now, when we see this, what we see is that we have a normal pH. So if you stop right here, you don't know anything about your patient. You go, okay, normal pH, we're good. Patient's pH balance is perfect. But when we look at the CO2, we go, wait a second. If we have a CO2 of 55, we should have an acidotic pH. But we don't. We have a normal pH, which is your first clue that your bicarb must be elevated to compensate for the acidosis being caused by the high CO2. And that makes this a fully compensated respiratory acidosis. Okay, so those are the three breakdowns of respiratory acidosis. Now I'm going to go a little further here, okay, because you got to understand some things here. So let's go back to where we started. 725, 55, 24. For those of us out there who are not living with chronic lung disease, if we get, let's just say we get a big bad pneumonia and we're at home and we refuse to go to the doctor, we will go into acute ventilatory failure, which means the failure acutely to remove CO2. Our CO2 will go up. This is what happened right here. Our bicarb, remember, initially doesn't stay the same because I live with a bicarb of 24. Okay, 22 to 26, you know what I'm saying. I live with a normal bicarb. So my bicarb will stay normal, my CO2 will rise, my pH turns into an acidotic pH. So this is a healthy individual who experiences an acute lung injury or an acute illness that affects gas exchange in the lung, and the body is no longer able to rid itself of carbon dioxide the way we normally do. Now, if I smoke every day of my life and I destroy alveolar tissue, then I'm going to impair day-to-day gas exchange. And with time, my CO2 will slowly rise up to this 55. Okay? So this is a different scenario from what I was just saying with the bilateral pneumonia. Forget that. Now, with somebody who smokes every single day of their life for an extended period of time where it causes lung damage, they get to a point where the gas exchange is no longer adequate. So the CO2 slowly goes up. As the CO2 slowly goes up, pH slowly goes down. And in response, bicarb will slowly rise to get us back into this state right here. So this is where your chronic emphysematic patients, your chronic cystic fibrosis patients, your pulmonary fibrosis patients, your Pickwickian syndrome or your morbidly obese patients, a lot of them live at this state with an elevated CO2, but with a compensated bicarb to bring our pH back into a normal pH range. Here's the key. We call this acute ventilatory failure, AVF. Acute ventilatory failure. It means acutely, I cannot get rid of enough CO2 and I'm going into ventilatory failure. We call this over here chronic ventilatory failure, CVF. This means over time, my inability to get rid of CO2 has been fully compensated by my bicarb, and I live at a state with an elevated CO2. We will intubate this patient. We will not intubate this patient. This patient's walking around their community right now. They're shopping at Target or Walmart or where, Kroger, it doesn't matter. But they're out shopping right now. Okay? So chronic vent failure is the advanced terminology to talk about a state of a person who lives in a state of a fully compensated respiratory acidosis. And acute vent failure is how you would talk about a patient in a state of uncompensated respiratory acidosis. Okay? Now I tell you those because you have to understand that as students and new grads, soon to be new grads, and for all respiratory therapy, you go to a doc and say, hey, we got an uncompensated respiratory acidosis, the doc's going to go, okay, let's intubate him and put him on a vent. But if you go to him and say, hey, doc, we're in a state of acute, this patient's in acute vent failure, the doc immediately has more respect for you because you understand a greater, higher level of thinking and interpretation than just the basic arterial blood gas interpretation. Basic interpretation, right here. Uncompensated respiratory acidosis. Partially compensated respiratory acidosis. Fully compensated respiratory acidosis. Advanced interpretation tells you that you understand chronic vent failure. Acute vent failure. Now there's not any of this right now, okay? So we'll talk about that in just a little bit. Now, before I wrap this up, there's something I have to show you, okay? Hopefully we're good with acute vent failure and chronic vent failure. I'm going to erase all of this, and I'm going to put two blood gases up here on the board for you. .40, 40, 24. 7.37, 56, and 32. Now, we already know that this is normal. This is me. This is us. This is where we live right now. We live at a state of a normal pH with a normal CO2 and a normal bicarb. Not that much different from a chronic vent failure blood gas where they live with a normal pH, on the acidotic side, high CO2, high bicarb. Both these people right now are up and functioning. Like I said earlier, they are standing in line next to each other right now in security waiting to go to Las Vegas. Okay? These two people are perfectly fine. But when these two people go into acute vent failure, it looks different, and you need to be able to pick it up. So I'm just going to say over here that we understand that this is chronic vent failure and this is normal. Okay? Now, when we go into acute vent failure, what happens is our CO2 goes up. 55. Our bicarb initially stays the same and our pH goes down. Okay? Acute vent failure, please put me on a vent and get me better, right? What happens when the chronic vent failure goes into acute vent failure? Same thing, but just with different normal values. And you don't know really what their normal values are unless you have a tracked history of normal day-to-day blood gases. So all we know is that their CO2 goes up. Let's just say to 70. Their bicarb stays the same. That's what happened up here. Bicarb stayed the same. CO2 went up. And pH goes down. Now the difference in this, and the reason I'm putting this in is because I want you to understand this, okay? I want you to be able to use these terms very effectively, even if your preceptor or your current instructor doesn't use these terms. I don't care. I care about you being the very, very best respiratory therapist you can be and being able to use these advanced terms, okay? So, remember, if this person up here, normal, who lives at a state of normalcy, CO2 goes up and pH goes down, we call this patient is in acute vent failure. Now this person, they also have now gone into acute vent failure. But that acute vent failure is superimposed on the chronic vent failure. So this blood gas would be interpreted as acute vent failure superimposed on chronic vent failure. You would intubate both of these patients. Okay? Now, depending on this patient down here, knowing they have a history, you would try BiPAP first. But if that pH is south of 725, you're going straight to mechanical ventilation because this is probably too late for BiPAP at that time. But these patients are more tolerable to higher CO2s, so you have a little bit more leeway. You have a little bit more time to try to get that CO2 down with a non-invasive ventilator. I wouldn't want to intubate this person, but if I had to, this would be an indication to intubate them. They are in acute vent failure, even though it's superimposed on chronic vent failure. So I hope this makes sense, because this is the key that a lot of us get tricked up on. You're going to take your MBRC exam, right? And you're going to have a question like this. Let's do a practice question. Let's just erase all this. Patient comes in, 7.35, CO2 of 70, and a bicarb of 38. And the question is, what do you want to do for this patient? Well, with this information, we don't really have enough to really make a decision on. But what we know we don't want to do, because what they're going to try to get you to do is to look at this and to panic and to think we need to intubate and mechanically ventilate. But because this is normal due to the bicarb, then this is not the answer. This is monitor your patient. There's nothing to do for this patient. This patient is where they live. Okay? So you will not intubate this patient. Now, patient 2 comes in, and they look like this. This is patient 2. They come in. What would you like to do? You want to start oxygen therapy? Let's see. Let's go A. You want to start O2? B, you want to give albuterol because that's what we do to fix everything. C, you want to intubate and mechanically ventilate. Or D, do you want to start them on Airvo? Well, this is the only information you have. You don't even have a PaO2 to monitor. So it's not Airvo and it's not O2. You're not told anything about the presence of smooth muscle constriction or bronchospasm or breath sounds or nothing. So it's not albuterol. The answer here is intubate and mechanically ventilate. Now, why? Because this patient is in acute ventilatory failure. Okay? Now, leave the same options up there and just change this right here. This is bicarb. Remember, this is bicarb. This is CO2. This is pH. Just change one number. And what we see now is that we have an acidotic pH with a high CO2 and a high bicarb. So what do we want to do now? Do we want to start them O2? No, we don't even have any O2 information. We don't even have any information saying that they're hypoxemic. And even if we did, this wouldn't be the best answer because you fix ventilation before you fix oxygenation. There's one scenario where that's not true, and I'll cover that in the respiratory alkalosis video. But for now, even if I put an O2 up here, it wouldn't be the answer. Neither would Airvo. Neither would albuterol. We're still going to intubate and mechanically ventilate this patient. Why? Because this is acute ventilatory failure superimposed on chronic vent failure. This is the illustration of a blood gas of a chronic CO2 retaining emphysematic who is experiencing an acute exacerbation. And they present with this high bicarb and this high CO2 and this low pH, and that's telling you that they are in acute vent failure. The pH tells you they are in acute vent failure. The bicarb tells you they live here chronically. And all you know is that the CO2 is higher than normal. That's all you know. You don't know what normal is. You just know it's higher than normal. And that makes this acute vent failure superimposed on chronic vent failure. And don't forget that one of the indications for mechanical ventilation is acute vent failure. So when you see a patient in acute vent failure, whether it's superimposed on chronic vent failure or it's just acute vent failure superimposed on normal. See, that's the way we should teach it. We should say acute vent failure superimposed on normal. But that would be weird, right? Like you don't have to say superimposed on normal when it's just acute vent failure. But you do when it's acute vent failure superimposed on a chronic ventilatory failure patient. Okay? Hey guys, I hope this helps. I hope it makes a little bit of sense. And if it doesn't, please leave me your comments, your questions, your concerns. And by all means, if you haven't already, just hit the subscribe button and turn on all notifications. You'll get a couple of videos a week, and if you don't like them, unsubscribe. That's it. It's real simple, guys. I'm just here to help. Let me know how you need the help. Okay? Best wishes.